My name is Victoria Wilson, and I am really excited to be giving this Boost Your Knowledge presentation today. The first little part is going to sound a little different. We noticed we weren't recording in the middle of the talk, so I'm just going to cover the first few slides here, then it will jump back into the group session. But if you don't know me, I am here on the team at 4TFM. I'm also a working birth doula. I have been a birth doula for the last 10 years. I've been to just over 100 births, not because I think numbers make a better or worse doula. I just think it sometimes helps to know the context. Like, what have you seen? How many repeated patterns have you been able to witness and practice? So that's why I share that information. But I've been doing this since 2015. I live in Central Kentucky, and I have really grown to love, honestly, working in the hospital setting and kind of figuring out how to crack the code for my clients to have an empowered hospital birth, to get options that they want. And I'm going to share some of those tips with you today. So these are our kind of objectives for this meeting. Again, this is going to be a mix of just sort of some best practices. I'm going to share some of my own success stories and just some ways that I have found to effectively advocate for my clients. And we are talking today about the context of the hospital system, although it's important to remember advocacy happens at all times, hospital, home, birth center, wherever our clients are, we are going to be advocating for them. And we need to just always remember that that is our main goal. So one of the most important things we do as a doula these days is advocate for our clients, but I feel that it is very often misunderstood. If you were to look at this slide, tell me, what do you think constitutes advocacy? And I'll give you a second to look there. I think some of these examples are maybe a little more intense, a little more confrontational than others. Some people think advocating might be confronting. That's not always the case. Some people also think that advocating is, advocating is perhaps advocacy or kind of, writing policies, I guess advocate and like being an advocate for somebody and activism. Maybe you would say writing policy, talking to institutions, political policy, things like that. I feel like that's a little more under the realm of oh gosh, my words are leaving me. That's perhaps under the realm of activism. So advocacy and activism are kind of different, but what is an advocate? Some of these things might be advocacy, some of them might not be. I think it's really important to remember that advocating is going to be as unique as what our clients require in birth. That's okay. Emily, I'm seeing that you're saying advocacy could be not making policy, but encouraging change. Yeah, sometimes for sure. Or maybe that's a little bit of activism or advocacy, but depends on, I guess, what's going on. But for us, when we're thinking about doulas in the birth room, doulas advocate with clients. And I really think it's helpful to think about, I'm going to nerd out a little bit. Show my roots here of going to a school that was kind of super into the classics. And one thing I had to do in school was learn Latin. And when I was looking at the word advocacy, I was like, man, that word right in the middle, VOCA, is actually a Latin word, voca or vocare. That kind of means to talk, to call, to summon, to shout. And that's literally where we get this word advocacy from. So it started, in the Latin as someone who's calling. And when you use that term, the vocare, meaning to call, and then you add in the ad, right? Adduction, that means to call away, right? Or to call in, like one who's called to aid. Ad, right? Ab is away, ad is in. So you're calling someone into a situation. And then it kind of came from there, from just that simple VOCA. In Latin, you would say voca. The V is pronounced as a W. It broaden to be like you're calling someone to your aid, and then that turned into more of this formal, like legal pleading, making an intercession. You might even remember from high school, like world history, right? That was normal to have patrons of the arts. people who were advocating, like some rich, lord or lady would say, "Oh, I want a poem written in my honor." So they're paying money, right, to an artist to do that work for them, advocating that, hey, this person should be able to live and do their work, and I'm going to support that. That's kind of where this word comes from. So I think that's just helpful. Remember that, right? You're called into a birth to be an advocate. You're literally ad voca. You're calling in to plead and to promote whatever that person you're advocating for has asked you to do. So the reality is the action steps of our advocacy are just as unique as the clients and the births that, that might unfold for them. That's why kind of in this talk, I'm going to give you some different examples of how it might look. Don't take this as a one size fits all. Like advocacy really is going to look unique based on what's going on. Here's some big examples. I would say advocacy most often looks like in the birth room: ensuring clients understand their rights and opinions and implications of decisions being made. Also, remember, this is a job of a really good care provider, giving true informed consent and refusal. In a perfect world, doulas would have to do a lot less advocating, right? Because providers would be doing their job. But because it's not a perfect world, we help bridge communication gaps between clients and providers. It might look like asking some clarifying questions, reminding clients of their birth plan. To be a really strong doula advocate, it does require that you have a lot of clarity and confidence and also respect for both your clients and the birth team. And I was just hinting this. We all need to remember that client education is not the same as giving medical advice. I've seen a lot of talk in the medical community lately of like doulas should not be allowed to, educate, or like they shouldn't be giving medical advice. And what they're really saying is you shouldn't educate your clients. And we need to just remember giving medical advice and giving information are not the same. They're two different things. Especially as a doula, be mindful, telling someone, oh, they scheduled an elective induction for you next week. You don't have to go to that. That's a care plan. You're practicing medicine without a license. And if you make a habit of that, you can go to jail for a long, long time. And I don't want that for any of us. So we're not talking about practicing medicine without a license. We are talking about education. So when you're working with clients prenatally in the birth room, you need to be very careful about that your education is coming off as education. Hey, client, your doctor has said you're 39 weeks and they want to schedule an induction. Can I give you some information? Would you like to know what that is? What does elective mean? Take this information and go back to your doctor and talk to them about it. We as doulas can't definitively tell clients what step to take or not. And again, be careful because it can trip up on you. The induction one, you don't have to show up to the induction is the one I see the most. And I would say the second one I see the most is past your due date. The client asks you, what can I do to get labor started? And then you say, oh, well, you could take a spoonful of castor oil and put it in this midwife's brew I'm going to send you. That's a care plan. You're practicing medicine. You're giving an intervention. You can give them information about those things and say, go talk to your provider. Let me help. Maybe if there's miscommunication, if the provider is really hostile to that plan, you can help make a conversation happen, but you can't actually give the medical advice. So to know what not to do, it sometimes is more helpful to know what you should be doing. I really liked these 3 pillars from SS Yam, who actually was, this study was written at a school close to me. I was kind of surprised to find out, the University of Kentucky. She defines soft advocacy. Doulas is mostly doing soft advocacy in these 3 pillars: making deliberative space, culture and knowledge brokering, physical touch, and spatial maneuvers. This culture and knowledge brokering, I think, honestly, in some ways, this can be the where doulas really shine. I was just talking about this with after our Fit for Doula debrief. We were talking about doulas are really valuable because we see how every single hospital does something. And we can tell clients, well, hey, I do this a lot. When we have an epidural, let's say, in the one hospital that's so stringent, it's like you can maybe have sips of water and ice chips. It's helpful for that client to know, hey, I just want you to know, if you were at the hospital across the street, they would be bringing you a tray of like clear liquids with broth and jello and, and little slushies. Like, I just want you to know, other places, it's done differently. So you can talk with your team about that. Like, that culture and knowledge brokering is so helpful. And helping them understand, okay, why is this doctor really mad? Well, this doctor is, is a resident, and the attending is mad at him. So that tension you're feeling is between an attending and a resident. It's not about you. Like, that's culture brokering. Parents may not know that, but you do. You can help. So we will, as the presentation goes on at the end, I'm going to give you some really specific ways to do that. But first, I think it's sometimes helpful to talk about barriers. What are some barriers to providing advocacy that you have come up against in your practice? And again, you can write in the chat, or if you want to unmute for like 30 seconds and give me some examples. What prevents you from advocating for your clients? The threat of being removed, Jessica says. Yeah, I hear that, right? Doulas, again, we have this fine line, right? It's not really a regulated profession, which is beautiful in some ways. It gives us a lot of freedom, but it also means people can kind of do whatever they want with doulas. We don't have some clear, plain ground rules, right? Plain rules in place. You could easily be removed um, for whatever reason. you know, yeah, that's one. Any others come to mind? Of course, I have some examples, so I like to hear what you guys say. Supposed hospital policy. Yeah, that's another one. That's a really good one. Barriers to advocacy you might be facing is that a nurse or doctor, whoever, is saying, well, we can't do that. That's policy. Diana says maybe the staff dislike hospitals. Yeah, 100%. Clients can sometimes be a barrier to advocacy. Yeah, that's interesting. Definitely. So here's some common ones. I like some more examples you guys are coming through, giving educational information that could lead to poor outcomes or experience. Yeah. You have to tell me more about what you mean with that, Krista. The nurse not allowing room for it. Sure. So these are all some kind of common barriers. Power dynamics in medical settings. We're talking about, some of you are hitting on that. Doctors maybe taking offense easily or disagreeing with, like, let's say a doctor has a complex against a group of nurses in the room and you're trying to work with the nurses, but the doctor, that's a power dynamic. Institutional resistance or misunderstanding the doula role. I would also say, institutional resistance could also fall, like hospital policy kind of falls in line with that. Just this is the way we do it here. I don't really know what to do differently. Internal barriers, maybe you as a doula are kind of afraid of overstepping because you don't want to get kicked out. Maybe you don't have a lot of confidence. Maybe just as a person, you kind of want to be a peacemaker, not rock the boat. There can also be cultural, racial, and systemic inequities, right, that impact birthing experiences and can be a barrier to advocacy, right? One of the kind of well-documented cases we know is that, right, Black and brown, people, moms giving birth, sometimes cannot be listened to or their reports of pain not taken as seriously. That's a barrier to advocacy. If you're trying to say, hey, no, you're not listening. My client said XYZ, you're not listening to her. You're not listening to us. That's a barrier, just not being heard for whatever reason. An example I can share from my own practice is I was supporting this client during a TOLAC, and she had she was with a private practice that had a midwife, so her provider is in the room as a midwife, but with the practice not affiliated with the hospital. It's just kind of, they had privileges there. This nurse was so upset that this client was having a VBAC, which is kind of funny to me, right? Because we're like in labor, like the birth is happening. The VBAC has obviously like been approved by somebody because we're here. But the nurse was so upset about this. And this was actually my client's second VBAC. And the client was like, I really think I don't want to be continuously monitored. This was back before, believe it or not, Monicas were a thing. So clients like, I don't want to be on the monitor. I want to get in the shower. And the midwife was saying, that's fine. I'm in here. I'll just Doppler you. That's reasonable. This is your second VBAC, talked about that with the patient and the client, and they said, okay, fine, that sounds good to me. So the client's laboring away in the shower, hitting transition, and midwife's literally sitting in the shower with her, listening with the Doppler. It was beautiful moment. And then this nurse comes in and says, oh no, we can't be doing this. She needs to be on the monitor continuously. She's a VBAC, and we're trying to say, well, that this is literally her provider in the room. We're all cool here. This is kind of approved. And the nurse says, well, I'm going to have to go talk to someone about this. And I'm not kidding. She calls in the hospital lawyers and an OBGYN on a Saturday, gets both of these people into the floor. The OB comes into the room, the lawyer is standing outside telling my client that, she's breaking hospital policy, like she could kill her baby. It's terrible. So that nurse, right? Interesting. That was even with a supportive provider in the room, but because of the power dynamics in this hospital, that midwife didn't have as much autonomy as, like, let's say the OB did. So this client had a great support team, doula, supportive midwife, partner was there, but even still, we had a disruptive birth because this nurse was like, nope, not on my watch, and literally called in um, an OB and a lawyer on my client, which has not happened since. So that was really interesting to me, you know. Um, so that example, and I'm sure so many that you guys have, are showing that sometimes the biggest barrier to advocacy can be communication. Um, Whether it's like cultural, we're not understanding where you're coming from, where I'm coming from, just clearly communicating what's happening, birth plan preferences, whatever. So the most effective way to prevent that is to practice clear, respectful communication. And this is kind of, we're getting into some of these nitty gritty. You are going to get the slides afterwards, so don't feel like you have to screenshot or take notes. We're just going to email these to you, and you can have all this for yourself. But um, and I have to thank my research assistant, ChatGPT, for many of these. But it was funny because I was kind of asking different questions to try to get some good, like a good kind of handout tip sheet for you guys of words to you, like how can we phrase this? And it was funny because what ChatGPT came up with, I was like, wow, I do all of this. This is exactly how I practice. But I love, it's just succinct, orderly, and this is very clearly a conglomeration of what the internet says is good advocacy practice. It was affirming to me to see, yep, this is kind of what I do. And it's helpful to have it in like a succinct format for you. So the first tip for clear communication would be use I statements to clarify your intentions. So that would be something like, I just want to make sure that, Susie Q has time to make decisions. And this works well because it's not right, it's not confrontational. You're not blaming the provider necessarily for a failure to do anything. You're just, again, you're practicing what we want to see everybody do, which is give that patient autonomy. We want to practice centering birthing families and care. So I just want to make sure, they had a chance to understand what was going on. I know it was really important for my client to have time to make decisions. So I just want to make sure she had like 5 minutes to think this through, right? Voicing that, very appropriate. Um, Other things, this is kind of those soft advocacy skills. One of the kind of examples was that plain dumb technique. This is sort of creating space, for questions. This is sort of an example of that. Just trying to make some open-ended questions. You might be asking an open-ended question that you very well know the answer to, but you're asking it so that you're forcing that hospital staff member to also verbalize it. So something like, can you share more about why you're recommending this right now? One I've used a lot is, when the provider comes in, we're having that discussion of breaking water. And the provider almost inevitably will say something like, well, breaking water just going to speed things along. I'm just going to do a check. I thought I could just break your water while I'm in there, right? You can say something like, oh, well, is there any other way to help labor progress without breaking your water? We're doulas. We know the answer to that question, but by verbalizing it out loud, you're kind of forcing that the provider, whoever, nurse, midwife, you're forcing them to admit the other alternatives. You're making that space, and you're just kind of making us all think it through as well, making the whole room think it through. In a way, I think this does show some respect to the provider. Like Emily said, I'm sort of in the process myself of becoming a nurse and a provider. And hopefully, one day, like many years from now. But as I'm going through it, I have to say I am building a lot of empathy and respect for the expertise of a medical professional or a nurse. Like they have done work. They have done a lot of work. They've balanced classes. They've gotten a C or better, in some really tough courses. So it's not that they are ignorant. They've done work and they know things. It's that these people in these jobs can get so locked into how the system works that they kind of forget, oh, we're supposed to be focusing on the person in front of us. And that's really that beauty of what we provide as doulas. We're making this space. We're asking the questions. We're slowing things down. And I'll tell, someone is already saying in the clients, teach your clients to use brain. I have to say, sometimes that brain works if you trust your provider. Some providers do get whatever the case is. Maybe they're not staying up to date on evidence. Maybe they do like controlling the process and don't want to introduce alternatives appropriately. It's both this balance of you need to have clients that are prepared enough coming in, ideally, to know kind of what's going on, but also it's most ideal if you can trust that provider's word. And if you can't, it is tough, right? Maybe this water breaking example, you say, hey, anything else we can do to speed up later? Maybe the provider says, no, this is on the way. We know that's not true, but what do you do? What do you do if we're using brain and they say there's no alternatives, this is it? Like then you're kind of in this weird hostile power struggle we're trying to avoid. But I think this is kind of just a nice way to start conversations. More often than not, this really does work. Um, yeah, there's tons of reasons providers may not want to offer all the information. Like, yeah, someone's saying, Emily's saying maybe they've been burned. Maybe they just feel like the whatever I think is the best way to go, I can protect myself. And there's tons of reasons, but we're just trying to remember all we can control is our part of this. We can't control where people went to medical school, who trained them, what trauma they've been through, how they respond to trauma. We can't control, who's the administrator of the hospital, what kind of culture do they create. We can't control any of that. We can control how we show up and how we try to use all of these advocacy tactics, like kind of in a collective way to get some good wins for our clients. Another way, I think this kind of play for me, this often plays into like usually after I'm facilitating some question asking, I really do try to do that in context of the team. Like, hey team, let's say again, labor's going long, everyone's kind of getting impatient. I'll try to say things like, man, I know we're all so ready for you to have this baby. Has anyone else seen this? What worked to resolve it, or what other options are there? Or asking nurse, asking doctor, have you seen this is kind of a funky thing we're seeing. Have you seen this before? What happens? Like, and I think that can help just remind everybody in the room we are all in the same team. We're all here. Hey, we're all here to support this family. Maybe even looking at your clients and saying, I'll do this sometimes. I'll look at my clients and say, man, you have got a nurse and a doctor here who are like so focused on helping you have like the birth that you want. I think that's great. I'm glad we can like work together to make that happen. Even if it's not really totally great. I mean, I won't lie, but sometimes if it's just like borderline great, I'll just say, man, everyone here we're all just so happy to be here supporting you. I'm glad we can work together. I'll kind of like Yoda mind trick, like say the thing I want to happen, like Jedi mind trick. You can just sort of say that. I'm glad we're all working together. And that can sort of remind everybody, oh yeah, we are on a team. Neutral observations to de-escalate. This is a very effective one. Something like, I noticed my client is really overwhelmed for a second. Maybe we can just take a beat before we move on. Again, this is similar to that I can statement. It's addressing tension. It's not assigning blame. It's not making assumptions. It's just stating an obvious. I have used this before, literally in this situation. Something changed in the birth, a whole team rushes in. Everyone's having discussions over top of the client about what should be done next. And literally to the whole room, I just said, hey, everyone, I know, and I said, I know this is kind of an excited situation right now, and we need to make some decisions quickly. But since we have a second to talk, could everyone just introduce themselves to the client? She looks really confused and doesn't know what's going on. Could everyone just introduce yourself and say what you're here to do? And they looked at me like, oh yeah, we didn't do that. And then they all, I'm so-and-so, I'm NICU, I'm so-and-so, I'm cardiology, I'm so-and-so, I'm the attending OB. Like, it was helpful. And again, neutral, you're just stating the obvious. I think this is one doulas are most like adept at doing, echoing and clarifying client preferences. I really liked this example. Again, ChatGPT just knew. I've taught my ChatGPT so much about doula care. It like had these examples ready for me. But this is truly one I use a lot. The epidural is often when I find clients when I go unmedicated. As soon as like someone moans in labor, the nurse is like, well, we can call anesthesia. Do you need an epidural? Blah, blah, blah. Da, 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 da. Are you good? And I can just say, oh, well, I don't know if she asked for an epidural. And the nurse might push back, well, she's in a lot of pain. Don't you think we should call anesthesia? And I can say, well, I don't think they're asking for that. It's not, look, you know, I'll literally, sometimes I'll have my clients take out the birth plan. I put it on the nurse's station in the room, right under their charting computer. I put it right there and I'll like point to it and say, oh, well, in their birth plan, it said they wanted to bring up that conversation of like an epidural. They didn't want someone to suggest it. Like they said, they'll tell us if they're ready. And it's interesting. And I kind of, that's maybe kind of it's a subtle, but it's so powerful, especially putting that birth plan on, you know, it's that nurse's workstation. I stick that birth plan directly under the monitor for real. And then it's sort of like they're anchored to that space so often. It's just right there. They see it. And then you can literally point to it, you know, because sometimes I think that computer, you know, the monitor, that's sort of seen as like a locus of control and authority in the birth room. So I love just sticking the client's birth plan right on top of it and say, nope, you're going to come here to assess, like look at your tools, look at your screens, do whatever. But I also, we're centering what the client wants, you know, in this space, gently echoing, clarifying, reinforcing. I think that can be very effective. Um, Space and time, you can always do this. I think, again, this is probably another one most doula organizations are going to cover if you've done some sort of training. Um, I also like to point out doulas, sometimes you need to give the client space too. I'll do that. I'll sometimes make sure I offer that with like nurses, doctors, midwives in the room. If we're maybe deciding C-section, whatever, you know, I'll say something like, man, this is a big decision. Client, like I can step out, we all can step out and give you two a second to discuss this. Would that be helpful? Sometimes they say yeah, and sometimes they're like, no, you stay here, everyone else go. And I think that's good for the medical team to see, right? Like I am their chosen person. They want me to be here. But I think even as a doula, we need to remember sometimes we do need to leave the room. Sometimes even if, you know, we can check ourselves, like, are we putting some bias or some preference into the room the client feels like they need to follow? Are we checking ourselves? But also sometimes clients may just make that up, right? I hired a doula, so I'm assuming she wants me to whatever, not get an epidural or never get a C-section. And they might need that space, you know, themselves to talk. Um, yeah, I think that just remember you might be included in that too. This was helpful. Again, we were talking about brain earlier. This bias framework is interesting. Like I said, brain, I'm not a hater on brain. I just don't think it always works if you have a shady provider. I guess I'll say that. If we have a provider who's stuck in their ways, they're always going to give a same answer. Brain doesn't work because they're not going to give you a straight answer. Brain works when the provider is really good at giving informed consent and refusal. Not so great if they are kind of just in and out. But this, another B acronym to remember, bias, was interesting. Brief, inform, ask, support. Again, hey, just quickly catching people up to speed. They didn't want epidural. They're hoping to avoid unnecessary interventions. Is that okay right now? Thanks for helping us keep their goals in mind. Someone's mentioning in the comments, yeah, of course, asking if parents have changed their mind. Please don't come away from this talk saying, you know, Doula Victoria said you can just override whatever the clients, you know, people do change their mind. We don't ever want to override a preference or if a plan has changed. We just make space for that. It just has to be a discussion, you know, and the clients have to be centered. So we just always refer back to them. I kind of like this model too. You can keep this in mind, brief, inform, ask, support, when you're working with a team or working with a client even, you know, hey, next time whoever comes in here, maybe you should just remind them what you wanted, ask or tell them why that's important, ask your question, and then kind of, again, put it out there, that kind of Jedi mind trick style of like, hey, I really appreciate you supporting me in this. Even if they're not completely supportive, just kind of say what you want to happen and see if that can change the behavior. Told you guys I was going to have practical examples, so we're going to do a little role play. I think we're doing kind of okay. We're doing okay on time. These are just 4 things. So again, those are ChatGPT. These are 4, and again, that's mostly how I practice. I was really glad to see that those examples were kind of like, yeah, I kind of do all that in some form. These are 4 things that I specifically do myself. I've taught this in other courses before. A team huddle. It's going to be common to do like the report, beginning of shift, end of shift. I insert myself into that conversation kind of towards the end. If a nurse wasn't already asking me, I will just say, hey, yeah, I'm the doula. I've been here since before she got here, and like here's kind of how things have been going on. Or I'll just kind of echo like, yeah, she was coping really well, and we just started getting uncomfortable at like 6:30 p.m. I thought we might could go do the tub next, something like that. If you were not like added in, I definitely sort of like make my own huddle happen, or not even in those shift change times, just like other times. If we have these big decision points, inflection points in the birth, you can kind of say that, like, hey, can we all just get everyone together and just talk about what's happening next? If the hospital is not suggesting that, you can suggest that as a doula. This is also a very effective tool I've been using. And I'll send you guys a template. You can make this for yourself. And the like with the replay, um, like slides and video replay. I made a card. This is a postcard size, so it's like a really big, like a large postcard size. Because I was finding sometimes nurses had a lot of questions for me of like, who are you? What are you doing again? I just put it all on a card and I hand it to them in the beginning of the shift. Like, hey, I'm Victoria. We're going to be working together. May not have a lot of time to talk, but here's me. Or I'll go out to the nurses station and drop a few off if I'm like getting water or I'm taking a break myself. Like just everyone loves the postcard. Okay, awesome. I'll definitely send you a template for this. But it's just effective, right? Put your contact info there, make it as long or simple as you need it to be, but this can communicate a lot when you don't have really time to talk in front of a client. Of course, obviously, you would not really be doing that, but they may have questions, but you're both kind of working. So this helps you. And then put contact info there, put your name down for like, and your number. I do that on the one I hand out. I have my phone number, like, and I literally say, text me or call me if you have questions. I'd love to connect with nurses in our area. Um, Social media is a tool. I have, if you're really vibing with a nurse, can I get your Instagram? Can I get your Facebook? I'd love to connect. I have so many nurses, that follow me now on Instagram and I follow them and Facebook. And this is a little conversation with a fellow nurse I had. I'll say this group has done nothing so far. I was kind of like, oh, I'll make a group for our local L&D nurses and they'll talk and it'll just take off and be great. It's really dead right now, but try it. Your area might work better than mine. Sometimes it's helpful, or especially in COVID. I started this in COVID, when I could say like, hey, what's everyone's policies, right? It was another way to get some insider information on like what's going on COVID wise in your hospital. Are doulas allowed? Are they not? What's the visitors like? Everyone wants to know about masks and vaccines. It was kind of effective. Sometimes I can ask some questions, I'll get responses, but it's kind of dead, but try it in your area. Maybe that'll work better. And then finally, Daisy Awards are really effective. Like that's, most people know what a Daisy Award is, but it's kind of like awards that nurses receive for their work. I definitely make sure I mention to families, if we have a really great nurse, I will grab cards for them to bring to the postpartum visit. I'll make sure I get the link from that hospital and I'll include that in our postpartum debrief. Hey, your nurse was great. If you want more great nurses like that to kind of rise to the top and influence others, you should submit a Daisy Award. And what was so cool is in the last couple of years, I've had nurses come up to me when like I'm on the floor and they'll show me their Daisy Award on my badge. Like, this was from your client, like I got that Daisy. Like that's happened more than once with like two different people. I can definitely remember right now. And that was just so cool. It was cool for me to see that they were so excited. And I definitely text the client like, hey, I just saw that nurse you had. She was so happy. She got a Daisy Award from like what you guys sent. Like it just spreads. I just kind of believe in like put more the good, put good in the stream that you want to see like flow downstream. So you got to start somewhere. That's very effective. That's language the hospital speaks. Very, very effective. And I'll stop sharing because we're gonna role play for a quick second and then I'll have a success story to tell you. Janet was asking if I've gotten feedback on the postcards. Yeah, nurses have loved them. I've had nurses come ask me for more. Like, hey, can I grab some more for our next shift? It's just kind of helpful education about what doulas do. A lot of times they don't know. A lot of times a nurse might really just think you're there to fight them at every tooth and nail. But having like an informational postcard you can like share and then they could pass around with friends can be very effective. I would never just leave it, like I wouldn't leave it just out. I would like get it to a human being that you're working with and then say, hey, like I want to make good connections in the hospital. I'd love to talk with you more. So really quickly, who would like to be my guinea pig for this role play?
I can.
Kendra, yes, thank you. Okay, friendly face. Okay, so let's say I feel like the epidural situation is probably common sometimes, like maybe clients wanting to go on medicated, but they're starting to get uncomfortable. And let's just say a nurse, I'll be the nurse who's like really pushing your client to get an epidural. Okay. And use some of these tactics. I'm gonna spotlight you so people can see us. Um, See both of us. Okay. So let's say that's what's going on. Okay, you're doing your doula thing. Um, I'm a former theater kid, so I'll really try to get into it, and you feel free to do the same. But okay. So I'm like, hold on, nurse coming in. Hey, okay, so is she ready for her epidural now?
She had actually said she wanted to go without an epidural.
She sounds like really uncomfortable though. I feel like it'd be so much easier for all of us if she just got an epidural.
Yeah, she is working really hard. Right now, she's using the ball to work labor, and she was thinking about getting in the tub next.
Mm. Yeah, client. Well, I really need to hear it like from the patient that she doesn't want an epidural.
Yeah, of course. Mom, would you like to have a conversation with your nurse?
Hmm. Okay. I don't know. Are you sure? Like I can just get anesthesia on the phone like right now. They're really and it kind of if you don't get one right now, like I'm afraid it's gonna get too far along and it's gonna be too late to get an epidural if you did change your mind.
Yeah, we can definitely have a conversation about that and keep that in mind. Does your hospital have a policy on when it's too late to have an epidural?
I mean, I don't know, but like don't you think it's just kind of hard when it's later, you know? I don't,
Yeah, definitely gets really intense, but this is something she really was feels passionate about and wants to try.
well, what if I mean, so I don't want her to be suffering. Like, do you think that if she changed her mind, she would let everybody know?
For sure. Yeah, we definitely talked about that during our prenatal visits. And if she changes her mind, she'll let us know.
Yeah, okay. Mom, you're gonna let me. Oh, you're okay, good. Okay, well, I'll check back later. I mean, I think she needs one right now, but whatever. I guess we can keep waiting.
Yeah.
Okay, good job, yay. And scene. Okay, good job. Thanks, Kendra. That was good. Yeah. So, and I think that's a good example of sometimes it is hard. Like, there's this whole conversation of like, do you ever talk for clients? Yeah. When someone's throwing up in the toilet in transition, I do speak for them, and and I kind of like make sure I know the points to say, like, okay, I'll look at the client and be like, okay, the nurse needs to hear from you right now. Like, what do you want? But I'll try to prime that conversation as much as I can, right? Of course, if things are chill, or obviously it's just a team, right? You're just as much a valuable part of that team as the nurses, as a client, as the partner. Like we can talk together like adults. But I think that's a really good example, Kendra. And that's definitely kind of what's happening in my mind is maybe the client really is in her zone, doesn't want to talk, can't talk. And I've, at least in my area, a lot of times the default from the hospital staff will be like, well, I need to hear it from her. Like you can't speak for her. And it's just, it is tough. It's a line, but we all kind of figure out how to walk it. And again, it's referencing back to, well, on that birth plan she just gave you, this is where we are. She hasn't told us that plan's changed. And just echoing, did you say no? And they might even be like, no. You're like, okay, well, I heard her say no. She said no. Like it's just echoing, affirming. But it can be tricky. But yeah, that's definitely an example of you might be talking for someone for sure. And I see a question. There's like we're very close, we're like 2 slides away from being done, and then we'll do questions. I also wanted to share some success stories from my practice that I've seen. I'll just talk about one of these because then I have a big one I want to tell you about that did involve changing policy. um, this was an example of working with a nurse. And this was kind of at a hospital that is known for not doing interventions. It's kind of weird. Again, I was talking about this recently with some doulas. It's a small regional hospital. They don't have anesthesia on site. They don't have a NICU. I think sometimes they just kind of let things go. And we had this issue where the baby was having a lot of decels, and the nurse is like, well, they don't like that side. Okay, we'll flip. Well, they're still 80. They don't like that side. They're still 90. And but then the baby would like recover, but they were down for like a minute or two before they would come back. And I was just like, we can't keep flipping. Like this baby's not cool. No one's calling C-section. The doctor's not even like in the hospital. He's in clinic across the street. And so I had a suggestion. I was like, wow, her water's broken. Do you think we could try like an amnio infusion since we already have like water is ruptured and see if putting some more water in there would give the baby some more cushion? And the nurse is like, well, yeah, I guess we'll talk to the doctor about that. And then she talked to the doctor. Guess what? Put an IUPC, did an amnio infusion, baby sounded much better. We had a healthy baby a couple hours later. So even things like that, the nurse wasn't making suggestions. No one was helping other than like flip flop this baby, even though they looked awful. Was it wrong for me to speak up? Am I giving medical care? No, I'm saying, hey, client, your baby doesn't look great. You know, we're trying, flipping isn't changing the heart rate that much. They have this thing called an amnio infusion. They can put water in your uterus and kind of give baby more cushion. Does that sound good? Do you want to talk to your doctor about doing that? Yeah. Client says, yeah, sure, whatever. That sounds good. She had an epidural at that point. Um, and that was successful, so you can kind of see other things. There's just there's so much power in knowing your place in a hospital and not being afraid to speak up. And again, the other examples on the screen are just like, I got to know these nurses over the years, that it's like you're walking into old coworkers together. That's such a good feeling. You kind of know who to call and they know you. This is the big thing I wanted to highlight before we ended. um Recently, like literally 2 weeks ago, this baby was born. This hospital did not have hydrotherapy. They have hydrotherapy available. It up until now has only been for like low risk. You have to be like completely perfect, not need continuous monitoring for any reason. Baby has to be perfect, no meconium. It's like very restrictive. So we're glad we have tubs. It's very restrictive on who can use them. This client is a VBAC. This hospital policy does require the VBACs be continuously monitored. We talked about that. Can you just decline? Can we make sign that the client declines that policy? We talked through what does this look like? And alongside that conversation, I was saying, well, hey, the hospital has these new telemetry monitors that can be submerged. Can we just change the hospital policy to let people having, TOLACs or any other continuous monitoring situation just use the tub? Can we just change, if it is a policy issue, we just change the policy? And I worked with, for a couple months, like writing to the midwives. I was like on message boards, finding nurses and midwives and other facilities across the country, trying to get their policy examples, like sending that to this kind of midwifery group that was supportive of this change. The client was sending letters to the director of the department, like, I'm really interested in this. I would rather have a home birth, but if you can just like let me use the tub, like we can change the policy. Not kidding you. The day that they met to review this policy, they did approve it. They approved a trial of like, sure, we'll do continuous monitoring in the tub. She goes into labor. I was like, this is the pettiest baby on the planet, and I love it so much. She goes into labor, uses the tub. She has a VBAC. It was like the most triumphant, beautiful thing. And even in this moment, I thought we were going to lose it because the mom's water broke and there was some meconium. She was post-date, so there was meconium kind of as expected. It wasn't like dangerous, scary meconium. It was just kind of normal. Your past her due date, light brown meconium. And the midwife was like, oh, I don't know. She has meconium. The policy still says like you can't get in the tub. You can't like get in the tub. Literally says can't use tub. We will not bring the tub in if there's meconium. And I was like, and I looked at the clients and I said, clients, like we are only going to push, like, this is your birth. If you want to push this, I'm here to help you. If you're cool and we just don't want to make a big deal right now, you want to focus on laboring, that's cool, whatever you need. And she was like, well, yeah, we've come this far. And literally I was like, okay, I'm like, is there any way I will go talk like to whoever, like we've come this far. Is there any way we can get an exception? The midwife leaves the room, was like, yeah, I agree. You guys are too close. You've worked so hard. You're literally the reason we changed this policy. I'll go see what I can do. She comes back 10 minutes later and she's like, literally the OB is like revising right now their trial policy that there's no, like meconium isn't an issue. She kind of removed all of these exceptions and the policy was just kind of blanket. If you're continuously monitored, you're okay to use the tub. And yeah, and then they rolled the tub in and we filled it up and she got to get in it. So that was amazing. That was just really cool to see, like, hey, all that work paid off, like that was some really good advocacy for everybody. The midwives, the nurse, the doula, the family, like that was really cool. When you get the slides, this is just like reminder of what we've talked about and how you can implement it, like practice this. If that role play situation, like if you are in any of our programs for TFM, we can do that in any of our open office hours time or any other time. Definitely take some questions, like find a doula in your community, practice that. Debrief challenging situations and really ask, like, how could that have gone differently? Could I have done something differently? before the birth or during the birth? You know, could the hospital have done something differently? Do I need to be part of changing policy on behalf of my client because of what happened? And then again, just kind of stay current yourself. You know, if we want to see best practices from everybody, we have to do the best practice. Um, to sum up advocacy, I think it is being kind, remembering others, and just doing the right thing. Um, and you know, at the end, I'll have of your slides, you can see I'll have references and things for you. But I think sometimes we forget that advocacy is just about being kind, you know, and doing the right thing. I often give the example of, let's say you were in a library and the rule was no talking, and you saw an old lady getting assaulted in the corner of the library. Would you say something? Would you talk? Yes, you would. Doesn't matter what the policy is because you're doing the right thing. You're being a kind human. You're thinking of others. You know, so I think we can get caught up either in our own doula organization's rules or perceived rules. We can get caught up with hospital policy. And I think sometimes we just forget like being an advocate is doing the right thing and standing up for somebody who doesn't have a voice. So, um, yeah, let me take the questions. Has anyone had success advocating other than pushing for other pushing positions besides being on your back? It was the one thing they wouldn't allow in my last birth, though she was on a squat bar prior. Yeah, Rachel, that's a really tough one because pushing, I would say like sometimes the best defense is a good offense. So for my success for advocating other pushing positions has started prenatally, talking, knowing from clients, okay, you want to push in different positions? Okay, well, your next OB appointment, you're going to talk about that, you know, and you're going to ask them for some clear examples. Tell me about a time when you've supported a client pushing hands and knees or whatever alternate position. Then when you get to the birth, you're again putting that birth plan on their little like right locus of control like the computer and the monitor and say, hey, this is her birth plan, really wants to push in alternate positions. That's something I'm planning to help her support her in. I just want to make sure the team knows that's what the client's expecting. You know, again, you bring the client in, is that right? We still want different positions. Okay, cool. Like you kind of put that there. And then again, before pushing, I would just kind of bring it up again, like, okay, as a reminder, like refresh. If she didn't want to push on her back, we're gonna like move, you know, around. Um, Another, yeah, another thing you can do too is sometimes like if the hospital team doesn't come in, like, you know, I've had to learn this, don't call them in when I was a new doula and people were pushing, I would be like, oh, I need to call them immediately. It's like, you can let them just like push, like follow their body for a little bit and then they'll come in when they see like the monitors change. You know, you don't have to rush. You can just let them do their thing, the client do their thing. But having said that, literally a birth I was at last week, I had this happen. The client was saying, I don't want to be on my back. And I was like, I asked several different ways, like for her, like, oh, hey, the OB's here now. Instead of the nurse, pushing with the nurse, the OB's here. Did you want to talk to the OB about going on the side? And this client, this was a weird situation where the client was like, this OB was pretty, the client wanted a lot of low interventions. So this was a very high intervention OB, but she like loved the OB. So the client was at that moment, she was like, well, okay, whatever. If again, this was a lie situation. The OB was like, no, there's no position that reduces tearing. Like, and she said something like, if you don't want to tear, have a 6 pound baby. It doesn't really matter how you push. So that's tough, right? I can't, what do you do in that moment? The client was like, okay, I love this OB. I trust her. I'm cool. And she kind of made that decision in that moment to be okay with what was happening. And my job, in a way, my job as a doula advocate was done, even though on the inside I'm like screaming and dying, you know. Um, the client says, you know, that's fine. I trust you, OB, whatever you say. So that can be frustrating. I don't want to make it sound like I kind of always have these successes and nothing like, you know, weird ever happens. Um, it does, but I think that's just kind of where you have to find out, okay, when am I pushing for this or when is the client pushing for whatever option, you know, and do a lot of prep work beforehand. The other thing clients can do is they can just move themselves. Like that's the other thing. They can move, you know, they can just stand up. They can turn over. You don't have to have permission. They can just do it. But again, pushing is tough, I think, because there's so much going on in the body. It is hard to have those moments. And right. And we don't need those fight or flight hormones going when we're trying to have a baby. So it's tough. So there's that weird balance of like protecting the peace of the room and then supporting your client. But I would also work prenatally with clients to be like, hey, you just move. This same client, when we got to the hospital, right? The hospital wanted to do like, let's hook you to monitors and do a strip. She just like went straight to the tub room, turned the water on, and got herself in. That was a good example. She was in there for as long as she wanted to be until she got out and did the like fetal monitoring strip. So, that just position yourself. Yeah, I'm glad that was helpful, Rachel. Someone else said, other than ACOG, what is a good resource for staying up to date on policy and practice? Yeah, there are so many. I mean, right? Like, Four Trimester Fitness Method is one. These Boost Your Knowledge sessions is a great place. I do really like when I'm specifically working in a hospital setting. I do like to know what like ACOG has said. ACNM is American College of Nurse Midwives. Want to know what they say? A1 American. Oh, you would know women something. Emily, you would know A1 off the top of your head, but it's like the neonatal nurses basically organization. I want to know what anesthesiology is saying. I just check all these professional organizations, or I'll look up a topic I'm investigating on those sites first because I want to be able to say, hey, your professional organization said blah 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 blah. Like that's powerful. What does A1 stand for, Emily?
I was just putting it in.
I know.
Association of Women's Health Obstetric and Neonatal Nurses.
Women's Health Obstetric and Neonatal Nurses. Yeah, they're a really good one. And A1 sometimes they're a little more like a nurse in a doula's role is a bit more congruent than like a nurse and then a provider, of course, because we're kind of having the same goal of centering the family in care. So um of course, yeah, I'll talk about that ACOG. So, ACOG, interestingly, they just put out this statement that Almitra shared, where they basically are describing midwifery care, and they're saying this is how to our providers, like to our OBGYNs, this is what you should do, and it's basically patient-centered autonomy, it's basically midwifery care, which is so funny. And I brought this up in a talk recently when I was at a hospital, and I said, look, like your own organization is actually saying you should practice what doulas do, putting families first, making sure people have information, tailoring care. I'm a partner in that. So you really need to be working with doulas because your own organization wants you to do this. The other interesting thing is, did anybody see ACOG? It was a month or so ago. They had a webinar that was like, working with doulas to promote maternal vaccines. And I thought, well, this is fascinating that it was a training from ACOG how to give information to doulas so doulas can talk to their clients about getting the vaccines that you want them to get. So that tells me, it tells me they maybe don't know a whole lot about some doulas and maybe what they think about vaccines. That's a whole other story. But it also tells me they know doulas are powerful. They know we influence clients and they're trying to leverage that now, which is fascinating, which is so funny. um, you know what I mean? It was just fascinating. And again, everybody kind of has different opinions. I don't think ACOG knows the scope of what people think in the doula world about vaccines, but they had a whole training. Um, it was fascinating, but it acknowledged they know we're powerful and they know that families trust us. And so I think at least it's a step forward in that direction of like, yeah, you better work with us because they trust, we're hired by families. So those are good places to start with. I mean, and then the typical like Lamaze, a lot of people talk about evidence-based birth as a resource. Like if we're TFM, we have Boost Your Knowledge and anything we teach, all of our classes, like we have, like up to date, we try to stay up to date and give you the most accurate information and come back and tell you when a recommendation has changed. But I think it's just staying in the world is helpful. It's also a really good idea to just do your own research, like go look on like when we talk about do your own research, I don't mean Google. I mean go to like Cochrane.org or NIH or PubMed and search a topic. Emily, you're so good about encouraging us to do this. Like go learn. You're not going to maybe be able to synthesize everything out there, but go see what some recent work was in an area, of question that you have. But go to the source, that's really helpful. Our buddy ChatGPT, they can give you references real quick too, like give you some places and go look at their reference. But yeah, I think that's the best advice. Like there's certainly places like Lamaze and like evidence-based birth that are trying to synthesize this information. If you want the actual information, just go directly to the source. That's the best advice I can give you, the professional organization or these places that are reporting the research.
Yeah, one of the things that our instructors certainly know at 4TFM, and when I'm working with new doulas, I'm always saying when you're in a conversation with a provider, one of the best things that you can do is speak their language. And by that, I mean understanding what the research is, know what the research is, know the studies by name even, so that you can respond to them with questions like, oh, I wondered what your thoughts and comments would be on this latest study that came out by, Brooks or whomever, that was speaking about pushing positions with regards to reducing the risk of tearing or whatever. Because then what you're doing is you're kind of throwing the ball back into their park as far as like, hey, do you know about this? Are you up to date on this, without coming across in some sort of like attacking way. But it is also bringing up the fact that like, hey, you actually have done the stuff, you have done the research, you've done the work, you know what the studies say, and you have educated your client on this. So I think that can be a way that can be very helpful with that.
I'll show you my favorite one that I have. And I'm not kidding. This is like, you can open my phone. This is bookmarked in my phone. These big topics that come up all the time, bookmark it, have it handy. This is my favorite one from the American Society of Anesthesiologists. Back in November 2015, they said most women would benefit from a light meal in labor. And this is from the anesthesiologist 10 years ago. I literally keep this bookmarked in my phone. And again, like it's funny because I was pulling this up for a client recently, and I did see there's another update they've given, like, well, I mean, like, don't get crazy, which is so funny to me. But I, no one else uses, like, just no, look it up, like, see what they've said about eating in labor. Like ACOG kind of had like a little, I think you see down here, they have a little addendum, which is so funny. Like, don't go crazy, but I mean, eat food. But this is helpful, right? You cannot argue with the professional organization. And I just bookmark these. I also bookmark a lot of 4TFM articles. They're showing positions. If I like need some help doing certain positions or trying to explain why I want to do something, bookmark pictures, bookmark articles, the inlet outlet opening stuff. That's great. Just have it in your phone. Have a little folder of like doula quick references. And it's great. Nurses, a really good nurse will be like, oh yeah, tell me more about that. I want to learn. Um, yeah.
For
Thanks.
sure, for sure. You can always become a 4TFM instructor too, and then you'll have gone through all that training and learned things that can be very helpful. I know a lot of doulas will say that everything they use in their labor, they feel like they pull right out of the Prep for Birth, manual. And I'm like, yeah, that is a manual that is for doulas. It's everything that I have learned and used and implemented over my years as a doula and as a birth worker. And I put it in that manual because I think not only can we teach our instructors that, but our instructors can teach their clients. Your clients are very, very intelligent people, and they're also very invested in their pregnancy, labor, and birth. And so there's no better time than to capture their interest in what does the evidence say? How can they learn how to best progress their labors? These are things that your clients are hungry for. And so when you're able to share evidence-based information with them, that empowers them as well. And it makes your job as a doula so much easier. So much easier.
I definitely agree. And you do a really good job, Emily, of like keeping up to date. Because I know you are actually combing through like all of the article. You're not just picking a few, you're like synthesizing and looking, and that's just part of why it's so valuable. Yeah, like that's why I love what we do, because you're in the field, you're working, you're kind of like seeing the big issues and you're addressing them with our instructors or in a class. And I would also want to leave like just to, because we're kind of at time, like I do want to encourage everybody that I've had a lot of cool opportunities this year, like literally this year after 10 years of doing this, I've had a lot of cool opportunities to talk with hospitals and nurses in the more direct, informal ways than I've ever been able to before. And people are hungry for change. Like people, the people who are kind of getting what's going on and seeing families make different decisions with birth and seeing them leave a certain hospital to go home or to go to another, like uh, it's just people are seeing nurses are like, hey, why is our patient census down? Oh, maybe it's because people don't like having a baby here. Why don't they like having a baby here? And they're asking those questions. And so I think that just be encouraged, like there is a lot of hunger for change. With maybe the kind of newer people in the field. And I just think it just takes time. That's why it's really important for you to be a good doula advocate, because you can be that inroad, you know, and you can use that influence for good. So
I wanted to share the link for 3 free classes that we'll be having this summer, actually. And we're calling it your summer of growth opportunity. But basically, we're going to be looking at 3 classes. They're about 30 minutes each. And we'll be talking about doula work in particular, how to prevent burnout with doulas, because it's one of the things we were talking about today in our Fit for Doula post-workout debrief, was just the stresses of trauma that we experience, and how can we recover from that. But the 3 different classes you'll see on the link, one is going to be holding space, not stress, burnout proof your doula practice. That will be one 30-minute session. Another will be making bank in birth work. How do you increase your ability to increase your income? And we have some ideas on that, of course. And then the last one will be on becoming a long-lasting doula with beautiful boundaries. And that's also some things that we talk about in Fit for Doula, as well as in our instructor classes and in our instructor group. One of the things that I would love to share with you is that Fit for Doula is something that I started, we opened the doors of it in November. It really started being laid on my heart about a year ago. And I was really feeling troubled by a few things that I was seeing happening with clients in the world of doula work. And one of the things really was the short-lived profession that some of the doulas were having, and then finding that, kind of the average work lifespan of a doula is about 2 years. And to me, that was very troublesome, because I thought, it takes more than 2 years to get really, really skilled and really comfortable with the work of doula. And so that was one of the things. And then also some of the doulas were saying, when I was doing my research and asking doulas about what are the struggles that you have, some of them were saying that, like, I hurt after I've been caring for a client in birth for a long time, or I've hurt my neck, or I've hurt my back or my shoulder. I have an injury from double hip squeezing for too long. And so I thought, okay, well, I can do some things about this, because I have a background as a personal trainer. I have a background as a doula and as a former nurse midwife. And I thought, how do I put this all together? And I thought, let's create a membership called Fit for Doula. So this is a shameless plug for Fit for Doula. But one of the things I also did was I wanted to keep the cost of the membership low. And so it is literally $39 a month. And we do 2 workout sessions every week that are appropriate for all levels of fitness and abilities. IQ from, sitting on the ball to sitting on a chair to sitting on the ground, high intensity to minimal intensity. But I want you to move your bodies. We're always telling our clients, motion is lotion, motion is lotion. Well, doula says it's the same for us as well. Motion is going to be our lotion and our longevity in this work. So in Fit for Doula, we work on mindset, goal setting, our physical fitness, so that our businesses can be fit. And so I'd love to invite you into that. Victoria dropped the link for that for you to maybe check it out some. We've got a couple of gals actually in this Zoom today that are part of our doula, Fit for Doula. You don't have to be an instructor to be part of Fit for Doula, but if you are an instructor, you get Fit for Doula for free, because I better, walk the talk. I want my doula, my 4TFM instructors also being fit for mind, body, and business. So that's a little bit about Fit for Doula, just if you're interested about that. So I don't know if anyone has questions. Oh, go ahead, Kendra.
You barely mentioned the doula debrief after Fit for Doula, and that is like the thing. It's amazing. The workouts are great too.
You should have been there today because it was rich.
So sad.
And we need it. We need it, right? We need these things to help us really excel in this work that we do, and we need each other in this birth work. We need each other in the postpartum work. And Fit for Doula does have birth and postpartum doulas in it. And so I'd love to invite you. I'd love to invite you to join Fit for Doula. I'd love for you to check it out. I think we have, Victoria, you better correct me if I'm wrong. We have an open, her eyebrows are going up. I'm just gonna say, we're gonna make an open invitation for people to try Fit for Doula.
Yeah, the code that free on me.
Free on me.
Yeah,
you can use that free on me. And I'd love for you to check us out. It is really something that I feel very passionate about, because I am, I'm sort of more, I don't want to say nearing the end of my doula career. That's not true, because I love this too much, but I want to be able to do it for a long time. And I always say, I'm 63 years old. How long am I going to be holding those legs up during labor? I want to be able to hold them up. I want to be strong in this work we do. And I want you to be strong in it as well. So I'd love for you to join us. A lot of the things that we do in there, I'm like, this is helping you do that double hip squeeze for all those hours at a birth. But anyway, so I invite you to join us. Try that coupon code free on me. And I'd love to see you in our workout on Friday. We work out Wednesdays and Fridays at 11 a.m. Eastern time, but we also record those workouts, so they go into the bank or the library on the Fit for Doula Hub. So love to have you there. Love to have you investigate our trainings. We'll be doing some virtual trainings this summer for Prep for Partner, which is our newest certification that's come out. And we'll be doing virtual trainings for the method, which is, that will be a 7-week training, once a week. 3 weeks will be for Prep for Birth, 4 weeks will be for postpartum recovery. And so those dates will be up and running very soon. Again, I understand we're doulas. We can't always make the virtual session. Don't fret, because we record them so that if you miss it, you can come back. And plus, if you're in our instructor family, it's a wealth of information in there, a wealth of support as well. So do want to let you know about those things. Deborah, unfortunately, you need to wait until your ankle has healed. Yes and no. Because I'm going to challenge you to come and do some of the upper body stuff seated in a chair with a TheraBand, because girlfriend, I got you. I got you on that. I can cue that too.
I would just thank you. Yeah, thanks for letting me talk today, and thanks everybody for coming. And just I agree with Kendra. Yeah, the fit, everything we provide here, I think is just so crafted for doulas, from that knowledge, education, to equipping you with ways to make money in your business, to helping your body be strong, and your spirit. Again, today there was just kind of a difficult birth that was debriefed by one of the doulas, and it's man, we really do need a safe place to talk about those tough experiences with each other, and get some just actual encouragement, which I think are it's just such a good group. There's no judgment, there's no blaming, no shaming. It's just truly encouraging, which is really rare to find sometimes just in the world.
We really protect that space too. I mean, it's one of the things where we record the workout session, but we stop the recording when we go to doula debrief, because we respect the privacy of those conversations and keep that sacred.
Yeah. It's just
it's really important. We need each other, right? We need our doula sisters. So Victoria, I want to thank you again for sharing.
Thanks for having me.
your talk today. It was fantastic. I'm so excited for, I know you won't be speaking on this topic at DONA. You'll be speaking on other things, but I know you're a gifted speaker and teacher. And so I'm just really excited for DONA. I don't know who's going, but we'll be there.
Yeah, we will be. Rumi. Yeah, thank you. I'm excited too. It was fun to do this. Thank you guys.
Anyway, thank you so much. And we will see you at the next one.
Bye.
Bye.